Hi, everyone. Today I'm going to be talking about the intake process, specifically biopsychosocial assessments. And I'm actually going to pull up a document that is pretty close to what the university is using right now. It's a document that was developed when I was clinical director in Sacramento. And anyway, every agency where you work is going to have a little bit different documentation. But overall, I just kind of wanted to go through the basic steps of the biopsychosocial process so that you can see which parts of the assessment need to connect to other parts of the assessment, why it's so important to have a presenting problem, why it's so important to document medical necessity, how it relates to your theoretical orientation and case conceptualization, and how that then feeds into your treatment plan. So without further ado, I'm going to share my screen. There we go. So hopefully you can all see that. It should say biopsychosocial assessment and treatment plan template. Again, this should be pretty dang close, if not exactly what the university has on file. But again, given that a lot of you in practicum are out there in the world in different locations, probably using different templates, but this should give you a basic understanding. So the beginning, there's always going to be the place where, put the name, date of birth, primary language, referred by, all the basic information, biographical information of the client. The first section where it says description of client, and in parentheses here it says objective, observable, give evidence for any subjective observations. So I don't think at this point I need to describe the difference between objective and subjective. Hopefully I don't. But I just keep it mostly to what you are observing and, how they're dressed, if they're dressed appropriate for weather, if they're, apparently well groomed, those types of things. If they appear their stated age, things like that. If you are noticing anything very subjective, or you have an opinion, you think about something, you really just need to say as observed by or as evidenced by if you offer your opinion. But I really don't think the description of the client is really a place to offer too much of an opinion quite yet. After all, I think it's important that we aren't entering into the relationship from a place of judgment. So we're really observers, and our judgment is reserved for later, and that judgment should be clinical judgment, not personal judgment, right? So okay, so presenting problem. So what are the symptoms that the client is reporting, and why are they seeking counseling? So there's kind of several pieces to presenting problem. One is why does the client think they're there? What is the client actually wanting to get out of therapy? And then also, like, the second part of that is, what are they telling you? What are you hearing? What are you observing? What are they telling you about their symptoms that are causing a potential functional impairment? So those are the two things that really need to be documented in this section: are what are the symptoms and what are the functional impairment? And this is a section that we actually need to come back to a few times, probably especially for new therapists, where later on, as you're writing your diagnosis, you really need to come back here to the presenting problem and make sure that the diagnoses that you're looking at match up with the symptoms here. And if not, why not? Why are you looking at those diagnoses if the symptoms aren't documented here, or if there isn't a functional impairment, or if the functional impairment doesn't match the diagnosis? So one of two things is happening. Either you haven't captured all the symptoms here and you need to fill in, this section better, or you're diagnostically you're off. So the presenting problem really should match up pretty close to the DSM and what the presenting symptoms are in the DSM for that diagnosis. I mean, obviously not everyone's going to have all of the symptoms, but following, 5 out of 7 or 3 out of 8 or whatever that diagnosis requires, making sure that those symptoms are actually listed here and that you actually have evidence in behavior of those symptoms. Okay. All right, history of the problem is also a very important section diagnostically. In this section, we're talking about onset, severity, and duration of symptoms. And I please do not write family history here unless it's relevant to the onset of the symptoms. So if there was some precipitating event that involved a family member, or if there was a tragedy in the family or something like that, then that little piece of the history could go here, so that we're documenting onset, right? But yeah, if other than that, there's another place for family history. Okay. And again, everyone's going to be using different forms at different locations. So please adapt this for this forms that you're using. Okay. So one more quick thing about history of the problem is we really want to know, did it start 6 weeks ago? Did the symptoms start 6 months ago? Did they start 2 years ago? Have they been there since childhood? Was there a precipitating factor? And, when they do happen, how bad is it and how long do they last? So, is it like on a scale of 1 to 10, 10 being like the most severe, 1 being like very mild? Try to get a number if you can in there. Duration of symptoms would be like, does it last all day? Is it like twice a week? Is it, does it last for 2 weeks? Are they having trouble sleeping every day? Is it just a couple days a week? Are they having trouble getting out of bed every day? Is it just a couple days a week? There are some diagnoses like major depressive disorder that require a specific onset of symptoms that lasts at least 2 weeks. And so understanding the onset, severity, and duration of the symptoms is really key to your diagnosis. Okay, so mental status. Depending on what state you're in, you may or may not be allowed to do mental status exams without your clinical supervisor being right there with you. But in most cases, you'll be able to do a mental status exam. You just will have to have your supervisor sign off on it. So activity is really what's going on with your client. Like, what are you observing? And keep in mind, mental status is a snapshot of what's happening right here, right now, not like what's been going on with the client all week. It's actually what's happening right here, right now with the client. So activity is like psychomotor activity. What, are they fidgeting in their seat? Are they, biting their fingernails? Or, what's going on with, are they blinking a lot? Are they, are you noticing any tics or anything like that? So activity is important to document accurately from what you are observing in that very moment. Mood and affect. I think this section gets confused a lot with students. So mood, I would just say really simply that mood is what the client reports to you, and affect is what you're observing. So a lot of the times we're asking ourselves the question, does their mood, is their mood congruent with their affect? So for example, is the client reporting that they're really sad and depressed, but they're kind of laughing while they talk to you? Or, are they smiling while they're telling you, a story about someone's death or something like that, where it's like it doesn't line up. Some people have like nervous laughter. So this would just be an area to just notice, not judge, but just notice if there's any kind of incongruence between mood and affect. And then thought process, content, and perception. Again, these three do sometimes get a little bit confusing for folks. So thought process is, I'd like you to think about sort of like how quickly someone responds to a question. So you ask a question and maybe like there's an inordinate amount of time, like 15 seconds or something, where they really are just not responding and not making eye contact, and don't appear to be processing the question very well. Or you ask a question and they answer a different question, kind of thing. So that would be an example of kind of thought process. Content is, what are they thinking about? So thought process is how, thought content is what are they what are they talking about? What are they thinking about? And, we're also thinking about, like, is their content congruent, with their thought processes too, because sometimes people are like tangential, sort of like all over the map. Like they're talking about this and then they're talking about that, and those two things don't seem to connect. And maybe eventually they come back around and they do eventually connect. But yeah, so those are a couple of things to think about. And then perception is really like, are they, when they describe situations in their life, so maybe they're giving you an example of how they're having a relationship difficulty, and then you say, can you give me an example? And they give you an example, and you maybe can see how their perception of that situation could be part of their difficulty. Maybe there are multiple ways to perceive a particular social interaction, and the way they're perceiving it is negative, and that is causing them distress. So perceptions, and again, you want to make sure that when you offer your observation or your opinion, that you're stating something to the effect of, as evidenced by, client gave me this example, and give the example. Cognition, insight, and judgment. So cognition is pretty self-explanatory. It's like, what are they thinking about? How are their thoughts? And this could also be a place where we're looking at kind of how they think, but not so much thought processes as much as like, are they able to, like, what are their cognitive abilities? Are they able to like have understanding about what you're talking about? Are they able to have understanding about what they're talking about, right? What's their level of insight? Like, are they able to self-reflect? Is there any reflexivity there at all? And then judgment, like, what is their judgment? And so in a traditional mental status exam, like they're doing it with a clinical psychologist or something, we might give an example of like, hey, if you're walking down the street and somebody drops a letter and there's a mailbox across the street, and you can't get the person's attention, what would you do? And most people are going to answer that question, I'll pick up the letter and go put it in the mailbox. But there's probably more modern examples of that. But it's just kind of like, what's the logical next thing to do? We also can give sort of other moral opportunity kind of stories that they can pick up on and answer. But it's a way of kind of getting a sense as to, who is this person and what would they do? Would they stomp on the letter and leave it there? Would they tear it up? Would they put it in the mailbox? What would they do with it? Anyway, I'm sure there's lots of other ways to get that information, but that's just one little example. And then physiological functioning, really, we're not doctors, so we really can't comment on physiological functioning other than, client was in a wheelchair, or, client reports, having difficulty walking, or client reports having diabetes, or some, it's going to be mostly client report. So on physiological functioning. So that's, unless there's something really, really obvious that is unmistakable. And even then I would say, as evidenced by, and I would probably ask the client, is there anything that I should know about your physiological functioning that might be of interest to, your mental health treatment? And so that might be a way of asking that question. By the way, there is a, gosh, what is the name of that book? There's a book that I used to recommend all the time, and they have a new version of it out for the newest version of the DSM. And it's going to come back to me in a minute. Nope, not treatment planner. Anyway, I'll I will come back to you on that. But it kind of goes through, and it gives you questions to ask that sort of help you. I have it on my shelf, so I'll pull it off my shelf in a minute and see if I can get it, or else I'll put it in the chat. But yeah, it gives you questions to ask your client to make this more just kind of flow easier for you. And then the last one is suicidal and homicidal assessment. And the most common reports I get from students are like, well, they didn't mention anything. And in the very beginning of, learning how to do a biopsychosocial assessment, we actually cannot tiptoe around this subject. We really literally have to ask, have you ever had Any kind of suicidal thoughts? Are you currently having any suicidal thoughts? Have you ever had any homicidal thoughts? Is there anything I should know about your history or your family history here around suicide, homicide, kind of stuff? And so if you ask it at least that clearly and they say, no, never, 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 then you can just say NA, client reported no suicidal, homicidal, thoughts or behaviors. Sometimes people will say, every once in a while I think about it, but I would never do it. That is significant to report. So anyway, so that needs to go here. So now we are down to family social history, work, school history for minors, if you're seeing minors. So a family social history, I don't need a book here. What I need is there a family history of mental illness? Is there a family history of intergenerational patterns that are relevant to what's happening with your client? I mean, clearly there's going to be plenty of family history that we could report here, but in the beginning, you probably are going to write a little bit of a book. But as you get more experienced in writing a clinical assessment, biopsychosocial assessment, you're going to learn to get more brief here, and you're going to learn what really is relevant to the diagnostic part of what you're doing here, and perhaps what isn't, right? But for example, one way of being brief might be the client reports to you, maybe there's a family history of child abuse or sexual abuse or something like that. You do not need to go into the history. You don't need to go into the details of what happened, other than the fact that client reports there's a history of, physical abuse, and maybe the ages, maybe from like age 3 to 7 or 10 to 15 or whatever. And client reports it affected him in this way, them in this way, kind of thing, right? We don't need all of the details of every little thing that happened. Now, if there are some significant things that are trauma related that need to be addressed later on as part of your treatment plan, then that would be significant, and you would mention those things here. But for all intents and purposes, having the family history, is there anybody in the family that's diagnosed with a mental illness? Are there any significant traumatic events, car accidents, divorces, deaths, things like that, interpersonal relationship difficulties? Really, like, is there a pattern of that, right? So we're looking for patterns and themes, and somewhat generalities, not too many details. Now, if you are keeping notes that you want to come back and ask the client later, that would be fine to keep in your notes on the client. But maybe those don't necessarily need to go into the biopsychosocial history here. Okay. So because a lot of this is diagnostic also, right? Because if someone has a long history of unstable relationships, there are several categories of diagnoses that could fit into. So that it is significant to note that here. Same with work history and school history. So there are some diagnoses for minors, for example, like ADHD, where we're looking at patterns of behavior across settings. So the minor would have to have demonstrated, at least 3 different settings before we could diagnose with ADHD or something like that. So they at school, at home, at church, or at school, at home, in sports, or at friends' houses, or something like that. If the behavior is isolated to a specific environment, that is also clinically significant and probably indicates that it's not ADHD and that it's more behavioral. So that's just an example. Work history for adults would go in this section, and we're looking for stability. We're looking for patterns of instability. We're looking for relationship history with employers and bosses and colleagues, and tolerance levels for, doing jobs they don't like, or, are they educated? Do they have a career? That kind of stuff. Okay, so strengths, I think, is also a section that sometimes people don't spend a lot of time on. So I like to tell folks, think about strengths as an inventory. You're taking an inventory for, like, what do I have to work with this client? what's in the resource bank here? And, part of our job as therapists is to help the client understand that they do have strengths and that there maybe have been situations or problems that they have worked through in the past. And, gee, how did you do that? Oh, you must be good at this. You must be good at communication, or you must be resilient, or you must be good at problem solving because look what you did. And so it's kind of like we're always looking for exceptions to some of the problems that they're especially from a solutions focused perspective. So this would be my kind of current primary focus, especially when I'm doing this kind of clinical work. I'm really trying to help build up the client as we go. And so I'm always looking for strengths. And I think just in general now, taking a strengths-based approach, no matter what theoretical orientation you're using, is really important and valuable in motivational interviewing and just, overall building rapport and motivation for change with your client. Okay, so I'm going to move up to legal and ethical considerations. There should always be a section in your biopsychosocial of legal and ethical considerations. It really should be for you guys as intern therapists. You really should be acknowledging to your client that you are an intern and that you do have a clinical supervisor who has access to your records. If there's any potential dual relationship or conflict of interest, this would be a place, to say this is what happened and this is how we handled it, or, hey, our kids play on the same soccer team, but we're not friends, and this is how we're going to manage that situation, or whatever, right? So, so this is the area where this is not about the client's legal issues or anything like that. This is your legal and ethical considerations for the therapeutic relationship, okay? All right, and then cultural considerations. So this is an area where I also sometimes struggle with teaching, just because students will come and say, well, the client didn't report anything. It's like, well, did you ask? So, I mean, the question to ask is, how do you identify? How do you identify in terms of like your cultural identity? Are there any holidays? You might ask questions like, are there any holidays that you celebrate? Is there a racial identification or a subculture or religious identification? Any of these kinds of things that might give us as the therapist context to the situations that the client's bringing to the table. And then I would ask myself, like, does this cultural identity require a deeper or more specific level of cultural competency than you currently have? So is there a situation where you might need to refer this client out to somebody who's more experienced with this particular, cultural identity? Maybe there aren't any other therapists in the area who specialize in this, and you're going to have to sort of muddle through it if, it's out of your realm of expertise, which a lot of things are going to be as a new therapist, right? And so this is where you might lean heavily on your clinical supervisor. You might lean heavily on your consultation groups or group supervision, and you might have to do some research. And you might also have to actually just put it out on the table with your clients. So, what is it like for you? When you're identifying sort of power and privilege between yourself and the client, sometimes the therapist always is going to have privilege, right? But sometimes we have marginalized therapists with privileged clients. We have privileged therapists with marginalized clients. And that power differential almost always needs to be addressed in some way, very tactfully. So that's something that we can talk about a little bit more in class, but this is just something I wanted to bring to your attention. This is also documented in the American Counseling Association. It's the Social Justice and Cultural Competency. Wait, I'm going to back up here for a second. It's the ACA Multicultural Counselings and Social Justice Competencies document. And you can actually just Google that and it'll pop right up, and you can click on it. And there's a whole section that talks about, how we ethically, like, what is our ethical and legal obligation to our clients regarding cultural competency. So that's for another video. And then the last question is, how will this be resolved or attended to? So it's really important for you to have a plan for like, how am I going to bring this up to my client? Sometimes it's an uncomfortable conversation. Sometimes it's not. And sometimes it's just depends on who you're working with and what that relationship dynamic is. Okay, that's all I'm going to say on that for now. Okay, so then we have the diagnosis section. So please use the appropriate DSM format here, and then case discussion, case conceptualization. So there are kind of two pieces to discussion / case conceptualization. In some biopsychosocial assessments, they ask for a justification. So this would be actually part of the case conceptualization would be justify why you gave this diagnosis. And this is where I'm saying go back to the presenting problem, go back to the history of the problem, those first two sections on your biopsychosocial, and make sure that the diagnosis that you just listed matches, that the presenting problem that you've listed, the symptoms that you've listed in the presenting problem match the criteria for the diagnosis. If they don't, you need to kind of go back to doing your differential diagnosis. If they do match, then this section, there's two paragraphs really here. One is, tell me why you diagnosed that. Like, not just the symptoms, but what are the behaviors and what's the context around those behaviors that is evidence for those symptoms in this client and in this client's story. And then the second part of it in the case conceptualization is, what is your theoretical perspective? I know a lot of you are using CBT, but I also offered up a solutions focus. We have narrative therapy. We have family systems therapies, lots of different perspectives, and that are going to change your conceptualization. So the conceptualization is really, how do I understand where the client's at? Like, how did they get into the situation? Was it through negative beliefs and faulty assumptions about themselves based on childhood trauma? Was it, is there an organic mental illness here that just started happening when they were turned 18 or when they went through puberty or, things like that? Or how did the client get into the situation that they're in, and how do you see them getting out? Meaning, like, what's the roadmap here? So I would give you an example, because CBT is super easy to use examples with, but I would say, through cognitive restructuring and helping the client role play different aspects of relationship dynamics, this therapist will support the client with blah, 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 right? Having the client do thought logs or, practice journaling every night before bed, or, things like that will help the client to change negative thoughts and negative self-talk into more positive, life-affirming, thoughts and choices or something like that. So that's the kind of languaging that I would see in case conceptualization. So we're looking for a justification of the diagnosis, and then we're looking for a theoretical conceptualization. Okay, so I think I'm gonna pause here because I don't want to overwhelm you all. But just know I will do another video on treatment planning as time goes on, and I will break this down and kind of show you how it ties back to the presenting problem and your diagnosis and your case conceptualization. So there is kind of a golden thread here, but I will make another video for this. So that's all I have for today. Thanks so much for watching this. I think it's going to help you a lot. Feel free to watch as many times as you need to and ask any questions that you have. Okay, I'm going to stop sharing. I hope you all have a great rest of your day, and I will see you later.